Welcome back to Open Med School. Today I am going to discuss about status epilepticus, the management of a medical emergency. So let us look into what is status epilepticus. Epilepsy, as we defined, is a tendency to have recurrent seizures, and seizures are due to excessive synchronous abnormal discharge of cortical neurons. We have already discussed this, and this can be divided into generalized and focal. Focal means it is originating from a particular focus in the brain, either in some networks of the brain. Generalized means it affects bilaterally, almost simultaneously. And now let us look into the status epilepticus. Conventionally, status epilepticus was defined as a seizure lasting more than 30 minutes or recurrent seizures in between patient doesn't regain consciousness. But this definition has been changed. The practical definition is a seizure lasting 5 minutes or more. It can be clinical and or electrographic seizure or recurrent seizure activity without recovery between seizures. So status can be clinical. Clinical means the involuntary movements are there. Electrographic means that there is EEG evidence of seizure activity but without any motor activity. So basically, status can be of two types. One is convulsive, that is with involuntary movements, and other non-convulsive. Hope this point is clear. Convulsive means there is a clinical evidence of seizure activities there. Electrographic means there is only EEG evidence. There is no clinical evidence of a seizure or convulsions are not there. And we call the seizures are refractory, that is not responding to standard treatment regimens. That is, the patient doesn't respond to the initial benzodiazepine plus another anti-epileptic drug. You can call it as a refractory status. So refractory status is defined as status epilepticus that does not respond to standard treatment regimens such as initial benzodiazepines followed by another anti-epileptic. Hope this point is clear to you. Now think that you have been called, that you have got a patient with a seizure in the emergency department. So how will you manage that patient? So the seizures can be initially a tonic phase, there can be a clonic phase, and then the patient can be in the post-ictal confused state. This post-ictal phase, even though there may not be any clinically any seizures there, the patient may be having a electrographic seizure, that there will be EEG evidence of seizure. So a patient who is brought unconscious, not regaining conscious, even if there is no motor activity, and EEG is essential to rule out non-convulsive status going on. Hope this point is clear. Now we will think about when somebody comes with a seizure activity or convulsions in the casualty, you should initially think about the few points. One is the patient is still seizing. If yes, how long it has been? More than 5 minutes, you can say it is status. What is the patient's level of consciousness? If the patient is unconscious remaining, consider ongoing electrographic seizure going on. Is this the first episode or the patient is having a previous episode of seizure on treatment has come with a status? If the patient is on anticonvulsant medications, what are they? Was the patient compliant on the drug? Did he withdraw the medicine? Always ask whether the patient is diabetic. Anybody coming with a seizure in the casualty, think about hypoglycemia, because it is a eminently treatable condition, and if you don't diagnose it sufficiently early, that can lead on to permanent brain damage. So these are the initial questions that should be asked when a patient comes with or a patient is brought with seizures to the casualty. Immediately order for IV line. So preferably 2 IV lines, one with normal saline. Have the airway, that is look for the ABC. Have the airway, breathing and circulation assist, and load a benzodiazepine, preferably lorazepam, or if the patient is convulsing, you can load diazepam. See that the patient is safe and all sharp objects are removed from the patient. Always perform a GRBS. That is mandatory. So when a patient comes with seizure, the most important investigation you should order for is a GRBS. Never miss hypoglycemia. Hope this is clear. Now think about what are the differentials that you should be looking for. For a patient has got a status, what are the conditions? Remember the mnemonic vitamins. Most of the conditions producing status can be remembered with the mnemonic vitamins. So V stands for vascular. So what are the vascular? Always think about intracranial hemorrhage, acute or chronic infarcts, subarachnoid hemorrhage, arteriovenous malformation, and always remember cerebral venous thrombosis. That is the V. Now think about I. I stands for infections, meningitis and meningoencephalitis. Then comes T, trauma, acute, or a patient may be having a traumatic head injury, they may come with the seizures. A stands for autoimmune. Nowadays, many cases of refractory status epilepticus are due to autoimmune encephalitis, NMD encephalitis. Think about systemic lupus, CNS vasculitis, that is autoimmune. M stands for the very important metabolic. This can be anything with hypo, anything with H, hypoglycemia, hyponatremia, hypernatremia, hypocalcemia, hypomagnesemia. So many of the metabolic conditions, always remember. Also think about ethanol withdrawal, drugs like cocaine, phencyclidine, amphetamines. So nowadays, with the advent of new generation drugs, think about the possibility of a drug abuse or a substance withdrawal. The next I stands for iatrogenic and idiopathic, that is first onset of epilepsy, or many drugs starting from antibiotics to many drugs can produce seizures. So think about, especially when patient is prone for a seizure. N stands for neoplasms, it's well known, and other structural abnormalities. So this is the, remember the mnemonic vitamins. Hope this point is clear. So it's very easy to remember the common causes of status epilepticus. But if you take the practice, 1/3 of the cases are due to patient who is on having an epilepsy coming with a status. Most often it is due to drug withdrawal. So that is the importance of asking history of a seizures in the past. Medication should also be kept in mind. Innumerable drugs, antidepressants, Antipsychotics, think about haloperidol. Many analgesics, the sympathomimetics. Remember metronidazole, very commonly used drug, penicillins. So, innumerable drugs are there. Think about the contribution by drugs. So, now we think about management of a patient at bedside. Be calm. It is likely that most people around the room are reacting with fear or panic. So, be calm. That is number one. Second, protect the patient from physical injury and aspiration of gastric contents. So, the patient should be kept in the recovery position. That is important to remember. Administer oxygen via a nasal cannula or face mask, especially if there is a risk of hypoxemia, and observe the type of seizure. So that is the initial management. Be calm at the site and go for the initial management as I have discussed. The most important investigation, which I already mentioned, is the finger stick glucose. So never forget to check the GRBS. See that 2 IV lines are there if possible, one with the normal saline, lowered a benzodiazepine, preferably lorazepam. We'll come to the dosage, and if time permits, go for further history. Is it a first seizure? Is the patient on anticonvulsants? Is the patient diabetic? Very important. Was the patient febrile? Because this may be due to an encephalitis. And observe the seizure. If patient is ongoing, seizure is there. So, what is the drug of choice? Drug of choice, initial management is a benzodiazepine. Benzo is the drug of choice. We can either go for lorazepam, diazepam, midazolam, or clonazepam. So benzodiazepine is the drug of choice. And when you are starting an IV line, avoid the antecubital vein, because due to the involuntary movement, very likely that can be blocked. Order for necessary investigations. When you start the IV line, take the blood for CBC, electrolytes, glucose, magnesium, calcium, ammonia, ethanol level, and toxicology screen, and anticonvulsant. If any doubt of hypoglycemia, give dextrose. And any risk of thiamine deficiency, along with dextrose, give thiamine. Always remember these two important points. So, load the patient with 50 ml of 50% dextrose and 100 milligrams of thiamine over 3 to 5 minutes if any suspicion of hypoglycemia. And ambulance should be ready because benzodiazepines can produce respiratory depression. There are different subtypes of status. We are divided into convulsive and non-convulsive. So, convulsive can be generalized convulsive status epilepticus. That is, patient has got involuntary movements with or without electrographic seizures. Patient can be in coma, but still electrographic seizures can persist. Non-convulsive status can occur, example, persistent absent seizure or focal seizures with unawareness or impaired awareness, previously called as the temporal lobe or complex partial seizure. There will be only minor motor movements. Always remember the practical definition, the time is only 5 minutes. So these are the important points to be kept in. And generalized status epilepticus is a medical emergency, because unless treated properly, it can lead on to long-term neurological damage. And again, there can be cardiorespiratory dysfunction, aspiration, hyperthermia, metabolic derangements. All this will lead on to irreversible damage. Serious injury can occur even when the patient is paralyzed. If the electrographic seizures are going on, even if there is no convulsive movement, because of the hypersynchronous discharge, the neuronal damage can occur. That is an important point to be kept in mind. And again, as time goes on, the generalized seizures can become increasingly subtle, especially after 30 to 45 minutes. The tonic-clonic seizures will disappear, and there will be only few mild clonic movements of the fingers or fine rapid eye movements, so nystagmoid jerks. Or there can be paroxysmal episodes of tachycardia and hypertension. That can be an evidence of a ongoing seizure. As explained, EEG may be the only method of establishing diagnosis, especially when the patient remains comatose. Think about ongoing electrographic seizure. This is essential to do an EEG when the patient is put on neuroparalytic medications. Hope this point is clear. Now we go on to the medications. So, as mentioned earlier, during the first 5 to 30 minutes, patient is having impending and early status epilepticus. Start IV benzodiazepine. Loading dose is 0.1 milligram per kilogram body weight. That is the dose for lorazepam. Midazolam can be given the twice dose, 0.2 milligram. The advantage of midazolam is it can be given intravenously, intramuscularly, through the buccally, or even through the endotracheal tube. That is double the dose can be given. Or you can give clonazepam or diazepam. Routinely, the advised is lorazepam. So usually 0.1 milligram for a 50 kilogram person, it is approximately 5 milligrams of, or 4 to 5 milligrams of lorazepam intravenously, and the dose is usually admission in such a way that per minute it should not be more than 2 milligrams. That is the usual loading dose. Previously it was said that only if seizure occur, you give a anticonvulsant or anti-epileptic drug, but now the recommendation is this should immediately be followed by a proper anticonvulsant or an anti-epileptic drug. So the preferred drugs are given intravenously. We can either give phenytoin, fosphenytoin, sodium valproate, or levetiracetam. All are almost equally effective. Phenytoin is given usually the dosage of 20 milligram per kilogram body weight. For approximately a 50 kilogram person, this will be around 1000 milligrams. The maximum dose of phenytoin should not exceed more than 50 milligrams per minute. So this will take approximately 20 minutes for the administration. Never push it and go. Should be given slowly. It should never be mixed with dextrose because it is intensely alkaline, and dextrose is acidic and it will precipitate. So that is why initially I said you should have two lines. One is just the one, preferably saline, should be given only through the saline. Phenytoin can produce extravasation, can lead on to problems. It can produce cardiovascular or conduction abnormalities, hypotension. So should be preferably given under monitoring. The prodrug of phenytoin is fosphenytoin, and that is little more easier to administer. It can be given faster, up to 100 to 150 milligrams of phenytoin equivalent. The dose is calculated as phenytoin equivalents, can be given little more faster, and that is advantage of fosphenytoin. And nowadays there is a tendency for giving sodium valproate or levetiracetam, which are also effective in controlling the seizure. Levetiracetam is given at a dosage of 20 to 30 milligrams per kilogram body weight. 20 to 30 milligrams per kilogram body weight. And sodium valproate is also almost the same dosage. And both of these drugs have got lesser side effects. That is why it is nowadays and safer to administer. If the patient is continuing to have seizures or subtle seizures or going into subtle status epilepticus, you may give one more dose of benzodiazepine, IV midazolam. Already I told the dosage, double the dose of lorazepam you can give 0.2 milligram per kilogram body weight as a loading dose, or it can be given as in infusion 0.2 to 0.6 milligram per kilogram per hour. Midazolam infusion can be given, or it can give propofol. Further anticonvulsants to be started per oral depending upon the, or intravenously. It can be valproate, levetiracetam, topiramate, etc. And this depends upon which medication patient was previously on. The patient has not responded to the second dose of benzodiazepine. You take it as refractory late status epilepticus. And patient should be taken off for general anesthesia. You go for pentothal sodium or thiopentone, and management depends upon looking at the EEG or electrographic silence. Other medications are occasionally used, especially magnesium. This is the drug of choice for eclampsia. And this is in a nutshell the management of status epilepticus. So once you have excluded hypoglycemia, benzodiazepine loading dose, lorazepam or diazepam or midazolam, followed by a proper anticonvulsant, anti-epileptic drug, that is either phenytoin, fosphenytoin, levetiracetam or sodium valproate. You may repeat one more dose of diazepam, and if the patient is not responding, treat as refractory status epilepticus by inducing coma. So we have discussed today the definition of status, that is a practical definition, seizure lasting more than 5 minutes. The types of status, convulsive, non-convulsive, and the convulsive status again you have divided into the depending upon whether it is a generalized or focal. We have considered the common causes, remembering by the mnemonic vitamins, and the guidelines for managing status epilepticus. Hope it was useful to you. Thank you.